CataractCoach.com, podcast series, episode number 73, with Dr. David Lockington, mentorship, surgical learning, and the 75th anniversary of the IOL. Welcome back to our Cataract Coach podcast. And today I have a very special guest, Dr. David Lockington, or should I say Mr. David Lockington. Welcome to our podcast. I have so many good questions to ask you and so much to talk about.
Well, thank you so much. And just to confuse you further, it's not Mr. It's actually now Doctor, because I'm a bit of a joke and did my PhD by published work during COVID.
Oh, PhD by publication. Yeah, that's very unusual in the US, but it is definitely in other countries. Tell me about that.
So it goes back a long way. It goes back to having kids at a young age, a wife who used to be a medic and then wanted to look after her own pediatrics. And I couldn't afford to take time out during my full-time training to do a higher degree. And so I knew that I had to keep publishing and presenting and making a real opportunity of research as it became available. And it was put to me over the COVID period that you could string them together into a PhD by published work. And I thought, I'm not sure if I'll be up to the correct status or scratch for that. And they said to me, no, you've got this wrong. It's been in the peer review literature. People do a PhD and hope to get publications. You've got the publications, so it's just getting the paperwork. So quite amusingly, I paid my year's part-time studentship to Glasgow Caledonian University, and then the following day handed in my PhD. Well, I still had to do the Viva, but they were quite confident that it was getting the credit for the work you'd already done. And I think that's probably one of my mantras, get the credit for the work you've done and do the best with the time available. I think that's a really important lesson in training and as a trainer.
So you must have 100, 200 publications. You have a lot of publications in our field.
I think I have 120 peer reviewed.
Wow. But that's 10x more than me.
Well, I mean, my mother was an English teacher, so writing comes naturally to me. It's almost therapeutic. But if we step back from the situation, any good research is based on a clinical question. Someone says, what's going on here? Is this novel? Is it not novel? Can we find an answer for the patient? Can we do something practical for the patient? And then you go to the books or the internet, and if there's a gap there, you have an opportunity to fill it. And I've been fortunate to have mentors around me who've always stimulated me to ask why, but also stimulated me to make effective use of my time. So deadlines, deliver it. Any patient you see could be a future topic, could certainly be a presentation somewhere. Take the picture, record the video, as you quite rightly say, and then share it. And you'll find other like-minded people who wish to share your message or find a gap in the literature. And there's niches, as you well know, if you act quickly.
Yeah, I think it's important, like you said, to connect with other ophthalmologists, especially ones that we see as mentors. I was just actually in New Zealand for the Ransco meeting, and I know you did a year fellowship with Professor Charles McGee there in Auckland.
Yeah, 10 years ago, an amazing year.
What an amazing guy. What an amazing place.
Inspirational. But again, you're on fellowship for a year. Make the most of it. My mentality is whatever you say, I'll double. So he's like, oh, you'll get a few publications. We got, double figures nearly. You'll get this number of graphs. We'll get double that. Really get the rewards for working hard. And if you're not afraid of hard work, you can shine. And that regardless of your background. Look, I have no medics in my family. I was working as a lifeguard in the summers to pay my bills when people were doing attachments with professors I didn't know existed. And that really lit a fire in me to burn bright and think, how can I make the best use? So for example, when we went on holidays to the West Coast, let's look up the great prof, go visit Uday, get some experience and get a lovely meal.
Have a nice dinner for sure. I hosted
an
an ophthalmologist last night too. I do it all the time.
Yeah, and that, that reputation of paying it forward speaks volumes because you've nothing to hide. You're helping other people. We are not competitors. We are colleagues and hopefully friends. And if we can be part of the I family internationally and locally, it helps our patients.
Well, that's the beauty is we have such a tight-knit family. There are so few ophthalmologists, such an unusual specialty that, yeah, we get to know each other quite well.
I think so. And it's just wonderful to have that support network, because sometimes you may not want to discuss things with your local colleagues, but if you have an international network, you can discuss things, tricky cases.
Right.
What would you do next? And your patients actually appreciate it. If you say to them, I was at this conference, I spoke to Dr. Devgan, this was his advice, they think, oh, great. You know, you're taking an interest in me. And even if they have a suboptimal outcome, they'll remember that you cared.
Oh, for sure, for sure. And yeah, connecting with colleagues is really the name of the game. This year coming up, Thanksgiving time here in the US in 2024, and in November, I told my family, I said, unfortunately, I'm not going to be participating in Thanksgiving this year. And they said, well, why? I said, well, there's this ophthalmology meeting in London that I just have to go to. And they don't understand, but I think hopefully they will one day. To tell me about what is this secret meeting or not
Yes.
so secret meeting.
So you're absolutely right. And actually, you are attending Thanksgiving, because we're all giving thanks for 75 years ago when Harold Ridley invented the first intraocular lens.
Right.
So UKISCRS is the UK and Ireland Society of Cataract and Refractive Surgeons. And I have the honor of becoming the president of that in November, which is shocking for everyone concerned.
No, it's fantastic.
But we thought this is our opportunity not to be insular. It's our opportunity to look out and invite the world to celebrate the 75th anniversary of Ridley's lens. So from the 28th and the 29th of November in London, just round the corner from the Tower of London, which is ironic because that's where Ridley's colleagues probably wanted to lock him up at the time, you know, because they thought he was a cowboy. They thought he was dangerous. And yet he was basically telling the ophthalmology world, you're doing it wrong. You've only done half the operation. And if you don't mind a little digression about the story, sure. Because I actually, let me just show you this. This is a phenomenal book, which I got as a gift. I'm sure you've all had that.
Oh, so
from
the Harry
David
Ridley book written by David Apple.
Yeah, absolutely incredible. And in it, it talks about how in the wartime, the cockpit got shattered and the perspex went into the pilot's eyes, and it didn't create an inflammatory reaction. And Ridley noticed this. And then a medical student one day after he did a cataract operation said, are you going to put a lens in now? And that was the stimulus he needed to go to the Rayner company at that time, who were closely linked with the makers of perspex, and design and put in the first intraocular lens. And now every single implant we benefit from, not just in eyes, across the body, comes out of the back of Ridley's braveness, vision, insight. And then in later life, thankfully, his competitors became colleagues and he got the recognition he deserves. So it's a wonderful opportunity for us to share the message, maybe educate the population as well as the ophthalmologists about what a great guy this invention is, but also maybe eye health is important. And in some countries, maybe it's not as promoted as it should be. So it's a real opportunity for everybody to say thank you, get together, and hopefully raise the profile for everybody.
Right. Get the message out. I mean, it's so wild to think that many decades ago, critics would call an IOL a ticking time bomb in the eye. And now we do a cataract surgery, and not just we don't put an IOL in, we even want to fix your astigmatism. We want to do a completely refractive procedure on you.
Yeah, I mean, the quality has shifted, the regulation has shifted, and the outcomes are outstanding now. You know, when you think about, there was an interesting quote in that book which said that about 100 years ago, the leading cause of blindness was cataract. And the second leading cause of blindness was treated cataract.
It was aphakia, right?
Yeah, because the technique was so bad. You know, you had to wait till it was ripe, so anything was a bonus. Whereas now we can get bespoke, personalized surgery to help people's lifestyle. You know, it's no longer pathology, it's performance. That's amazing.
Yeah, how far we've come, right? So instead of waiting till the cataract was ripe, so the young ophthalmologists say, what are you talking about? Like ripe like a banana? But at the time, you wanted to wait till the cataract was so bad, so blocking of incoming light, that anything, including leaving you aphakic with vitreous to the wound, would be an improvement.
Can you imagine living in that culture? Bizarre.
And now I have a patient, like, recently I did a refractive lens exchange, 60 years old, +4 hyperope, made her Plano OU with monofocal lenses. She thinks it's the best thing since sliced bread. She can't believe it.
Yeah, well, working in Scotland and golf is like the national pastime. There will be patients who come in and say, oh, I can't see my golf ball.
Right.
And my attitude is, well, there's no need to boast. but back in the day, your cataract was a golf ball. It was huge. It was a rock.
Right. So yeah, I mean, obviously our field has changed so incredibly much.
Yeah, we're very fortunate to be living in these times and generally being surrounded by patients who are happy. Without wishing to criticize other medics, doing general medicine, you patch people up. They're at a slightly worse state of comorbidity. You do someone's cataract surgery, 10, 15 minutes later, you've revolutionized their life. It's incredible.
Yeah, the reason I went into ophthalmology, I didn't plan on it initially, but in medical school, I saw a white cataract being done. And I thought the surgery was beautiful, elegant with the microscopes and all this. And then the next day, the patient was so happy. And I thought, gosh, very few surgeries in the body give that much of a before and after difference. And how many times does someone have like a brain surgery say, thanks for the brain surgery, I feel better. Here, they say, oh my gosh, thank you for this eye surgery. It's like the best thing in my life.
Yeah, it's incredible. I'll tell you a funny story about how I got into ophthalmology.
Yeah.
Because, as I said, I'm not from a family of medics. I was very naive at university. I was trying to pay my way through. And then you suddenly realize I have to become a doctor. And then they ask, what sort of doctor? So I did my first year junior doctor job in general medicine and general surgery. And a very elderly senior medical consultant said to me, David, what do you want to do with your life? And I said, honestly, not this. I said, I do not like general medicine. It's just organized chaos. It's weeks of night shift. It just did not fulfill me. I find it really not stressful, but it just wasn't. I couldn't see myself doing this for the next 40 years. And this is unheard of, Uday, but this senior consultant said, what were you good at university? And I said, well, I could always see the optic disc, And he said, well, there's a clinic here on a Wednesday afternoon. I will hold your bleep and you can go to it for 2 hours each week to get some exposure and experience.
Nice.
And that opened the door. Can you imagine any person nowadays saying to the junior doctor, not even in their specialty, oh, I'll do your job for 120 minutes so you can go and get exposure? And that man was called Ernie Hunter. And I touched base with him recently and I just said, 15 years later, I really want to thank you for what you did. In fact, 20 years later, because you gave me the platform. And I've always been hoping to then pay it forward to others and find ways to be supportive. So we talked about the publications, having an inclusive attitude. You're not doing free authorship, but you're saying, let's do this together as a team. Let's help each other. Let's support one another. Let's show a better way. And I guess that's where it leads into the simulation interest in teaching and training.
Tell us about that. So you have a huge interest in that.
Yeah, so again, maybe from being Northern Ireland, if people say no to you, it's a challenge to say, watch me. So there was a run, the Tennant Institute is a very historical organization in Glasgow. Basically, in the 1960s, 1970s, the Tennant Institute was like the Moorfields of Glasgow. In fact, Moorfields is probably the Glasgow of the South. But, things changed and all the rest of it. So there was a rundown library and an endowment fund. And I was very conscious that we did things in our training almost in spite of our circumstances, not because of our circumstances. So the IC simulator was becoming popular. Model Eyes were becoming more refined. And I thought we could really benefit from a bespoke, dedicated teaching and training hub to encourage our trainees, to give them simulation training so they're higher up the learning curve. so that patients aren't being exposed to unnecessary risk, because we know simulation takes the risk out of the learning process. And so we were able to revamp a couple of small rooms, built the bespoke simulation lab, got the it's now Hag Strike simulation, but the IC simulator, got little desktop microscopes with the bespoke model eyes. And then having done that, we can run courses. We can send the trainees to the dry lab to get the experience. They can bring the model eyes to the operating room to practice with the kit from the last patient. They can suture forever. And so we've really created a culture of safety first. And now people come from elsewhere to train with us, but also we can do hub and spoke virtual training. So we've really democratized that access, changed the culture for safety, and both the patients and the trainees benefit. And I have a much better night's sleep, so that's even better too.
Right. That was also very helpful during the pandemic.
100%.
Tell us about that.
So exactly. So what I find ironic is that the pandemic made all the men realize what it's like coming back from, 6-9 months of no operating, like the ladies who've been on maternity leave. And it's interesting, we interrogated our IC simulator to look for usage and duration of use. And you can see the little graph, which is bumbling along. Then nothing happens at lockdown. Then everybody wants to use it because they all understand the benefits, which the females have known for ages about keeping your skills up. So they taught us a lot of lessons in the pandemic, which was great. And so then, because we weren't able to operate, people are nervous about keeping their skills up, but also trainees in particular, who in the UK were redeployed to COVID wards. So they weren't ophthalmology trainees anymore. They were general medics again. And as I just suggested, you deliberately chose to be ophthalmology, maybe not to be a general medic. So they were worried that they were getting further away from their training. However, because they had 24-hour access to the simulation lab, they could keep their skills up. And so when they were allowed to train again and operate again, they had maintained that. And the work by John Ferris and George Sala and myself and others has shown that much lower rates of PCR than if you don't engage with simulation training. So, we can't afford not to simulate. People think simulations is expensive. Well, we did a paper asking the question, what's the cost of a complication? And it's far, far, far more. So it's a false economy to think, your adjuncts, the trypan blue, the capsule tension ring, the iris hooks, the Malugan ring, they're not expensive in the context of someone having a dropped nucleus or someone having a retinal detachment or endophthalmitis or cystoid edema.
That's far more expensive. Absolutely.
And the legacy cost to the patient. So in the UK, you've got like a theatre budget and a clinic budget, but people don't appreciate what happens in the theatre has a massive impact on what will happen in the clinic down the road.
Right. If there's a complication, you may see that patient back a dozen times in the next 12 months.
And their relatives have to take time off work, or maybe that patient hasn't got back to work. It's huge. So we want to do our best the first time, and we want to know what we're doing. I don't understand why a trainee wants to do something which they're incompetent at doing. Surely you want to be competent, which allows you to be confident, which allows you to execute your skill excellently. And that's where CataractCoach.com, free advert, is so good, because they will tell me, I watched Uday's video, I practice it in the dry lab, I'm good to go. And you have evidence, that this trainee knows what they're doing. And similarly, even at my stage, if it's been a while since I've done a Yamane, or it's been a while since I've done a iris suture, I can go to the dry lab, practice how not to do it, so then I can execute it perfectly.
No, I do the same thing. If I want to do an unusual case coming up, I'll watch a bunch of videos the night before just to kind of get my mind in that frame set. Yeah. Similarly, I wanted to learn a few years ago, I wanted to learn how to do DMEC.
Okay.
And so I said, well, I don't, what the best way is? I'm going to watch a ton of videos. So I got a lot of videos. I talked to some experts. I got their videos and said, hey, can I kind of amalgamate your videos, put them together and put them on Cataract Coach? They said, sure. And I'd watch how to unfold the scroll. I'd watch it 100 times to figure out all the origami methods that fold.
Yeah.
And so it's like, you know what? I learned by watching videos, hundreds of them, then doing it, and it was okay, and then doing it more and more. And like 10 cases in, I said, this is pretty good. Now I start teaching it to residents.
100%. And, people think you get in the UK, it's your complete certificate of completion of training. That's just the start of your journey. That's the foundations. I'm sure there's stuff you do now which you never did when you were in training, same as myself. So it's a journey of learning, even for those of us who are more senior.
Right. You have to embrace that. You got to learn forever. Because what I do today, I finished my training in the year 2000. In the US, it's a shorter number of years to do ophthalmology training. And so I finished the year 2000. There was no anti-VEGF. There was no OCT machine. There was no femtosecond laser. There was no lamellar corneal surgery. These didn't exist. So obviously, I can't just rely on what I learned in residency or fellowship or whatever. I gotta keep learning every year.
Absolutely. And that is the benefit of going to conferences. I'm a massive fan of in-person learning. Yes, webinars have been great. Yes, podcasts and all that filled a massive gap in the pandemic and connected us, and probably raised our profile as well, which has been great. But it's not the same. Do you remember the old Nightingale wards? They were called the hospitals with a main corridor, and all the wards went off at the old traditional hospital. A lot of business was done in that main corridor where you could chat to your friends or ask for advice or make a referral. And I view the corridor conversations or just after the symposium finishes at a conference. That's my Nightingale ward, where I can chat to the great and the good, show them a scan, ask them about a topography, get advice, or even just be reassured you're doing the right things. Then they've got all the dry labs and the other skill transfer labs. Really, we can't afford not to engage with conferences, because for me, it's what keeps life exciting. Otherwise, you could end up very isolated. There was a junior doctor room in the hospital. I don't remember there ever being a senior doctor room. You were on an on-call rota. These were your mates, your colleagues. You got through the busyness together. Now, as seniors, you're rushing between the clinic, the theater, the lecture, the private hospital, off to a conference. If you don't make an effort, I think you could get quite isolated. And I think that's where the navel gazing starts, and when the sort of burnout starts to feature, when you turn in on yourself. If you make the effort to reach out, be open, be available, be a good colleague, I think that makes you much more robust.
Yeah, I think you're right. No ophthalmologist practices well as an island, as an isolated sole practitioner without connection to other colleagues. It's difficult to practice. But the beauty now is you can have connection with colleagues around the world. It doesn't stop here.
Absolutely. And that, I think, is one of the wonderful benefits of being an ophthalmologist and part of the I family.
Yeah, in a lot of ways, it really is a family. Now, should we integrate surgical simulator training as like a mandatory part, like pilots do? A pilot has a mandated number of hours they have to do in a flight simulator before they're on real planes. Should we incorporate that?
So we have done in the UK, because as a result of my simulation work, I then became the national simulation lead for the Royal College of Ophthalmologists. And this sort of a model has been rolled out across the UK, where different departments have consultant simulation leads and then trainee simulation champions. But in answer to your question, module A and B on the IC simulator are mandatory for every UK trainee before they go inside the eye. Now, your next question is going to be, are there enough simulators? And the answer is sort of. There's about 50 across the UK, but unfortunately, they're at various stages of age. And it's not entirely clear who should be funding these, because if you're going to make it mandatory, it should be coming out of the hospital's budgets. It can't be bought, as our original one was, through endowment charitable funding, But I come back to my argument about it's cheaper to simulate and not have the complication than it is to have the complications. You also have to do a introduction to microsurgical skills course at the Royal College. So we're getting experience under the belt. But you made a very valid point about pilots. The reason pilots have to have so many flight hours, time in the sky, is for safety.
Right.
If you think of musicians, they do their scales. We went to the golf recently, and it's amazing that the golfers are on the driving range and the putting green before their round, do their round, and then go and refine after their round.
Right.
So we've got pilots, we've got musicians, we've got sports people, but we're arrogant surgeons. We just do what we like. We don't need to practice.
We already know everything. We're already
Exactly. It's ridiculous. So, you know, so you've got a choice. You either do things when you're incompetent, or you do things with the confidence driven from being competent. I remember as a junior trainee in Belfast, the clinic I was in was a diabetic retinopathy clinic, and we were doing some laser panretinal photocoagulation, and I had never done it before. And this guy had an only eye, and the supervising did 90% of it and left me a little triangle to laser. And the patient said to me, "Have you ever done this before?" And I had a choice. I could lie and say, "Oh, yeah, of course." Or I could say, "No, I haven't." And he said, "Well, you're not practicing in my eye. Go and learn what you're doing, and then you'll be able to do it in the future." Now, you could say, "How do you learn that?" And that was a gap in the past. You know, show one, do one, teach one. But now we have the ability to simulate. There are laser simulation eyes. So we do induction. So the junior doctor year in the UK will start again on the first Wednesday of August. And we will do induction, where they will be given model eyes, and they will sit at the YAG laser and the argon laser and learn how to do the laser. So whenever they're in the position to do it, they can do it safely. And the same with surgical skills, technical skills, even communication skills. There's not just about doing ophthalmology is more than just cataract surgery. And we need to remind ourselves about that sometimes.
Well, for sure. When I was teaching residents, I stopped 2 years ago, but I did it for 20 years, 22 years. We did everything that walked in the clinic. I taught every resident how to do PRP. We had a huge diabetic population, huge CRVO, BRVO population. So there's a big need to do PRP. And so you're right. Before simulators, how did we do it? Well, you'd find that one patient had a terrible CRVO or CRAO with very minimal visual potential and definitely needed the PRP. And well, let's have each resident do a few hundred spots to get the idea.
Yeah. And patients in that scenario are grateful when you're honest with them. If I had lied to my patient, that just is inappropriate on many levels. But in the patient you've just described, to say this procedure needs done and we're going to take the opportunity to learn, they are delighted to be able to support future medics.
Yeah, I had a patient once telling one of the residents who was a little bit nervous about doing it, and the patient's telling the resident, "No, don't worry, you're going to do a great job. I've got faith." I just want, what a beautiful patient.
Yeah, that's what you want. That's what you want.
Now, should we be checking or testing hand-eye coordination before accepting someone into an ophthalmology training program?
So I remember being told before I got into ophthalmology, you need to go and get your stereopsis measured and so many minutes or seconds of arc. And I had this piece of paper and I had no idea what it meant. You know, but tell them that you've got stereopsis. I don't think there's any evidence to that. But the problem we have in the UK, because we now have more of a conveyor belt system, it is 7 years, though it will be shorter, is it's very hard for people to bow out graciously if they don't like it, you know, or if you've got problems. I think there's a statement that a failing, this is hard for me to say with a Northern Ireland accent, a failing trainee is a failure of training. That's only true up to a point. Some people just aren't suited, and it would be wiser to counsel them into a specialty they are more suited for. But what we used our simulator to train the non-dominant hand. So we allowed them to complete the simulator with their right hand normally, and then we asked them to repeat with their left hand, and we were able to show improvements. I am fortunate in that I am naturally left-handed, but with my mother being an English teacher, she forced me to write right-handed, which apparently is not very good for the developing brain, but is brilliant for being an ambidextrous surgeon. And so whenever I was learning, I didn't know which instrument to hold in which hand because it kind of felt natural. But that's been a wonderful gift and skill to have developed. But you're right. You know, we can train the non-dominant hand. We can put ourselves, I mean, you hear about people, you know, brushing their teeth with their other hand, doing these sorts of things. Just go to the simulation room, put the needle holder in your other hand,
Just
and
do
do
it.
some sutures. You know, you don't need, brushing your teeth isn't going to help your non-dominant hand. Doing corneal sutures might. And you know yourself, when you have trauma cases, it's not perfectly sitting in front of you and it's easy to do. It'll be at an awkward angle. It'll be a stellate. There'll be iris and ciliary body and retina hanging out there. You're even going to put sutures in the wrong way to sort of get it together and then do it properly. You know, so taking these opportunities, because trauma, thankfully, particularly in the advent of seat belts, trauma is less and less from going through windscreens. So it's now, you know, more associated with bad behavior and a well-oiled society.
You hear it all the time. What happened? Well, it was just after midnight. I was minding my own business, and next thing you know, well, you know, it's funny you say that about suturing. Yeah, you need to be able to suture both right hand and left hand, both forwards and back suture, loaded both ways. You have to. And so one of the things I had for a resident was, yes, you got the surgical simulator. We had the IC. When I was at UCLA, we had published multiple papers about IC from UCLA, showing that there's certainly a benefit. But you know what else was really great? The resident who could do what I called the 10-10-10 rule. 10 rules of tenonylon in 10 minutes in the wet lab, on a tomato, on a grape, on whatever you want, on a simulated eye even. Can you do 10-10-10? And that just shows you can use your hands under a microscope.
Absolutely. Absolutely. And the thing also is, their theaters are often shut at night, but they're not locked.
Right.
So you can go in, and I know this is a podcast, but you know, you've got your wee model eye.
Yep.
You can go into the theater and you can suture that. So I would give that to a trainee, and I would say, do a penetrating keratoplasty.
Right.
Bring it back to me with 16 interrupted sutures. And we'd bring it back and we'd take a photograph, and then we'd break their heart and cut them all out, and then say, do it again, and compare the pictures. And suddenly you see, oh, I am improving, you know, as you quite rightly said. And with that comes confidence. One of the things I refuse to do with my first year trainees is I refuse to let them drape, because it's a complete waste of time. There are two ways to teach. You either do a modular approach of, you're going to inject all the lenses and we're going to work backwards to the operation or forward, or I'm going to give you half an hour of time, do your worst. The problem with that is it turns into this one really stressful operation, and if you don't do it right, it's a whole week before you get your opportunity again. So for me, if you plan nothing, that is what you're going to achieve. But if you say to the trainee, you're doing all the incisions today, you're doing all the rexus today, you're doing all the lens insertions today, so I don't want them wasting time with draping. So I drape, and then the patient is good to go, and then they can sit down and get on with it. Draping is for the intravitreal injections. They can learn that there.
Well, you know, I had a video on CataractCoach recently, maybe a couple weeks ago, where it was a graduating U.S. senior resident who sent in a video, and the resident had done, let's say, 200, 250 cataracts, and sent in a video. Now, I don't know who the resident is. It's totally anonymous. And it was not good. And it started with terrible draping and lashes all over the cornea, the whole case, and terrible iris prolapse, and they can't keep the eye in primary. And I gave an honest evaluation of it, which was a little bit strict, a little bit like, you know, hey, you need to do better than this. And the amount of grief I took from in the comment sections of why, no, you should be more encouraging. If that was your eye, how would you feel? And so I don't know. It's like, I think draping is certainly an important part. Obviously, you have to learn it.
Yeah.
But do we have to approach the new generation a little differently in the way we give feedback?
You want to get me canceled now, don't you?
No, don't get canceled. Blame it on me.
So I'll tell you a story I've used in a few talks. Whenever I get a brand new resident, I always ask myself, is this someone I want to operate on, my mother or my mother-in-law?
That's a good way of putting it.
But the reality is, everybody is someone's relative.
Right.
And so I think we're supposed to use that 4-step approach of feedback. You know, what did you do well? This is what I thought you did well. What could you have done better? This is what I thought you could have done better. And what I find is the vast majority of trainees are really conscientious and they want to tell you about all the things they did wrong. You're like, stop. This comes back to modular training. What were you trying to learn? So I find it easier to teach a brand newbie than someone who thinks they've done 300 cataracts and you're thinking, this person needs to start from scratch. I read a thing once about Nike, and I think they're based in Portland, Oregon, and they take all these amazing runners across the US, I'm sure, and elsewhere, and they bring them to this hub to learn to become world class. And the first thing they do is they teach them to walk. Then they teach them to jog. Then they teach them to run. And some people can't handle it because they were their state champion or whatever, their school, their university blew. Who are you to tell me how to walk, run? And my attitude is, I'm the person responsible for this patient. And if you want to operate on them, you need to meet a certain standard. So recording everything is vital.
Yes.
Because then you can go back and review it and say, what was going on here? And generally they know. Or, I didn't acknowledge this. I had the denial reaction to vitreous. It's not there. Let's just keep going. As you know yourself, complications happen often when things are complex, but the concern is what happens after you acknowledge it.
Right.
Once that capsule ruptures, what you do next matters. So it's not necessarily the rupture. And yes, you can just claim you're treating aqueous misdirection and getting rid of some vitreous. But it worries me when trainees say to me, I've no idea what happened there. Or, I forgot to record it. It's amazing, it's amazing when the video doesn't work, and you're like, really? The video didn't work the one time you had that complication? So I don't view that as a medical legal thing. I view it as an educational learning point. Let's go back and see what would you have done differently, or what could you have done? And sure, it gives great footage for conferences, but I record all my surgeries and I either delete them if there's nothing in particular, or I might want a little snippet. Yesterday I did an EndoArt, which is an artificial endothelial transplant. There's probably about 200 of them or so done now across the world. And I recorded it, obviously. But before I did it, I removed some graft sutures. And I thought that's a really good snippet of how to remove graft sutures without destroying the graft post junction. So I'll take that little clip and I'll do that in a teaching video. And I'll use the EndoArt clip to educate other ways. Have you heard about the EndoArt?
No, I haven't heard of it. Tell me more.
Imagine a traditional 3-piece IOL.
Okay.
You pull out the haptics so they don't exist.
Okay.
You shave off the anterior third.
Okay.
And you cut a 6.5 millimeter circle. So that anterior third 6.5 millimeter circle of plastic has a little F mark on it. I remember being told once, F stands for fantastic if it's the right way up, and something else if it's not the right way up. And because it's basically a piece of plastic, it's for patients who either there's no corneal tissue, or the eye is too complex for a tissue endothelial transplant, or they've had multiple, in my patient's case, multiple transplants, and they keep having immune rejection, and it's not appropriate to keep doing it. So behind a PK, or instead of an EK, you can strip the back surface of Decimase, pull this piece of plastic in the eye, do a full thickness suture at the top to make sure it stays stable, fill the eye with 10% C3F8. And what it does essentially is it compresses the cornea in the center. It will relieve the bullae, and the nutrients should hopefully go around the edges of the residual cornea. And so I've done it. I've done 3 of them now. One of them was in an elderly patient with some dementia and blistering infected bullae. And we did that, and it's clamped down the cornea. There's no bullae now. So her eye should be safe for the remainder of her days. And because it's a piece of plastic, essentially, you don't have the same drop requirements longer term, though you do need to keep that suture in for a good few months. And the patient I did yesterday, he's had multiple inflammatory related graft rejections. And you just know you do a transplant and it's going to be gobbled up within a couple of months. So here's hoping that that will give him that central access. And it's amazing to see the literature about how these patients are even improving vision, because conceptually you think this shouldn't work, but it's amazing.
Do they recover reasonable vision then?
Some of them do. I've only really used it in people with limited vision because I thought, well, I'll just go for tissue otherwise. But, you know, rubbing the eye, poking at the eye, the fact there's a full thickness suture in there does give you a bit more confidence. And for us, you know, if we have limited tissue availability, there's been some publicity from England where they have done some on the NHS there too. We did it a year earlier in Scotland, but we don't like to boast. But in their patients, they were using it as a temporizing measure as they were waiting. So someone had their cataract surgery. You knew they were going to decompensate with their Fuchs. They had this as a temporizing measure in the hope that they would get the DMEC tissue in the future, and they haven't removed it because it's been successful. So exciting times.
Yeah, neat innovations there. And I guess the nice part for you, it gives a clear view. It must have some sort of refractive effect too, right?
I think it will do. Time will tell, because of course your cornea will be so much thicker. Right. So as that decompresses, but yeah, some of the it's very thin. It's less than 100 microns from memory, so it shouldn't be too bad.
Oh, it sounds like neat technology.
Exciting times.
So here's another example of where you have to teach yourself how to do this.
Absolutely. So I watched the videos. I had the reps in. We went to the lectures at the conferences. And then when we weren't looking for a patient to do it in. We found a patient and thought, this would be in your interests. And that's a very important caveat.
Right. Well, you see that in the trainee doctors where they have a list of like, well, I want to do a Yamane, so I need to find a patient who needs a Yamane.
Yeah, absolutely. To go back to publications and presentations, what I also find is we have trainees and residents who have a list of, I need a publication. And my attitude is, we'll then do something publishable.
That becomes more of a challenge. Yeah.
And the presentations too. So I think historically, there was maybe more of a firm mentality that, you know, you pulled your weight in clinic, you got your surgical opportunities, and there were projects. But I think increasingly for our trainees, explaining to them the benefit of, if you do this project, you will have the opportunity to present it, hopefully internationally, if not nationally. You'll be able to then write it up. A project is only finished when it's published, and then you might, you know, develop this as an interest. You know, a number of my projects and publications have come out of just stimulation, and then it opens the next door, it opens the next door. You know, speaking to people in the university, making these collaborations. They love medical projects which have patient-related outcomes. Fantastic that they can be helpful. So there's such a wealth of knowledge outside of us. And if we tap into it, it makes life so much more interesting. And it gives you the opportunities to get your head above water out of the clinic. You know, there was a famous obey the ABCs, anything but clinic.
Well, you know, it's funny. That's one of the things where in ophthalmology, clinic's good.
Yeah, I enjoy it.
But the operating room or operating theaters, you would say, is so much more fun.
Absolutely. But the way you get the patients in the theater is that you see them in the clinic. So it's a nice marriage.
Yeah, no, for sure. Now, one of the things that when I was teaching residents, which I don't do anymore, there was a challenge in that in the US, there was a push, instead of having equal opportunity for each resident, they wanted equal outcomes. In other words, if one resident was very efficient and in a county hospital, which is a little bit slower turnover, it's not like my private surgery center.
Sure.
If that resident could do 10 cataracts in an 8-hour day, but they do 5 cataracts in an OR day, in the same day, should the resident who is slower get twice the number of OR days so they have an equal outcome?
That's difficult. And it reminds me of your American system is often criticized for incentivized medicine, because you get paid for what you do, you're going to have a natural default to do more and more. But I would say we're in danger of worse, because we're in danger of disincentivized medicine. Because I get paid by the NHS no matter what I do, where's the incentive to do the extra cases other than your professionalism, your conscience, wanting to be the best you can be? So whenever you have those trainees at different levels and different skill sets, it's very difficult. Trainees will say to me sometimes, I'm concerned about my numbers. To which I always respond, I agree, you're not seeing enough people in clinic. And they
know what they're thinking.
Yeah, and they will say, no, I meant my theater numbers. And I say, that's my point. Okay? If you want to be an ophthalmologist, see some patients with eye problems. So it's about being sure people need to have opportunity and fairness and access. But it's up to you how high you want to jump, how fast you want to run. And there's the old saying, if you want something done, give it to a busy person.
Right.
So, if people shouldn't be penalized for being brilliant, but if people aren't pulling their weight, then maybe they need to ask themselves, are you going to survive in this culture, or are you going to thrive? And I think very rarely you do come across some trainees who, unless they cheated in their medical school exams, are very intelligent, but their application and their commitment has changed, and they maybe don't want to stay on. Now, I don't believe that a good doctor should be defined by someone who doesn't work their schedule. Oh, you're a good doctor because you're here every night and every weekend over and above. But at the same time, showing some commitment to the specialty as a relationship with your trainer earns you the right to have more opportunity. Now, that could be open to abuse, and we need to be careful about that. In the UK, I have to train you whether I like you or not. And that possibly is why across Europe, simulation has become such a feature, as it seems to me that you have to kind of apply yourself to a department. You're not sent there. You are interviewed and chosen. So we need to be careful about that. But I fear there's a lot of talk about the waiting list in the NHS. And I fear that out of the pandemic, a lot of goodwill went out the window. And so if you're a junior doctor who wanted to do ophthalmology and you got sent towards the COVID wards as cannon fodder, I'm not surprised some of them are disillusioned. And if you think of Maslow's pyramid of needs in the hierarchy, at the very bottom is your physical well-being. You can't be the best doctor you want to be if you can't pay your rent, you can't put food on the table for your family. So society has changed. We need to find a way to encourage and inspire. And to me, given those opportunities, but both people meeting in the middle is the way to do it. So for me, here's a project, but you'll go to this conference and you'll hopefully get it published here. Do this work. Let's sit down. What are your learning objectives for this 6 months? What are we trying to achieve? I come back to what I said earlier. If you plan nothing, that's exactly what you're going to achieve. So what are we planning?
I like that.
What are we planning in this 6 months? And then at the end of the day, you've only got yourself to blame if you haven't achieved that.
Right. The mistake sometimes people make is they show up, zero preparation, zero motivation, zero plan, and like, I'm here, go ahead and teach on me. Go ahead. I'm just up and down, teach it right on my head. I mean, it makes no sense.
We aren't allowed to wear white coats anymore because of infection control stuff. Okay. But the white coat was phenomenal because you had the Oxford Handbook in your pocket and you could always just read it. And that was my upbringing. Just read it. Any dull moment, get the book out and read it. And now we have medical students coming through saying, we don't use textbooks. And you just think, you're not giving yourself a foundation to succeed. To say it's on the internet somewhere is not the same. Whenever it's 2 a.m. in the morning, to say, I'll find it on the internet. So culture has changed, but I think we have an opportunity to show people a better way. I never thought I would reach the stage of saying back in my day, like some grandfather figure. but I do think having a knowledge base makes the application of the knowledge much easier. And so I come back to what I said. It is much more fun to thrive than just to try to survive. And if you don't put the effort in, unfortunately, you will ultimately be left behind. I remember one of your Cataract Coach comments about, you're a shark. And that really stuck with me, because I know you're not. But in a business sense, in a competitive world, in capitalism, yes, you are. And so, if you don't think, how do I swim in the deep end? How do I make the best use of my gifts? Some point you're going to come up against it, and you're not going to know. Why did we do international fellowships? To get as many tools in our toolbox as possible. So whenever we needed it, we have the foundation.
No, you're absolutely right. I think that preparation really is the key. So the residents who, let's say, were complaining that, well, they only got 5 cases, though they had the same opportunity. I'd say, okay, you want equal outcome, but did you go to the lab? I said, show me the video from the wet lab of your 10-10-10, your 10 sutures and 10 minutes of 10 on nylon. Oh, I didn't do it, they'd say. And say, well, why don't we start with that?
Yeah.
Get that done, put that effort in. And I think the differentiating factor for a lot of it is, how much effort do you put in? And like you said at the beginning here, your certificate of completion, or here in the US, your diploma, your residency diploma, it doesn't mean much. It really doesn't. It's what you get out of the training program. And all those years you spent in your residency, how much knowledge and experience and hands-on could you squeeze out of it? As opposed to, let me just complete the months or the years and get the diploma on the wall, which is just not that useful.
So that's the danger with the 7-year training scheme in the UK, because you get 7 years to do this. So what's the rush? Whereas, other countries with shorter schemes, they have to get it all squeezed out of that 6 months or whatever rotation they're in. So I think you can live in your own little bubble. But again, speaking internationally, speaking to other trainers and trainees, being part of young ophthalmology societies, all these things make you realize, give you a bit of perspective and say, oh, I could maybe stretch myself a bit more. And I think also off the back of COVID, the seniors have turned around and said, I'm not sitting up to midnight writing papers for your benefit. If you're going to engage with me, we're going to get a good project. If not, okay.
No, it makes a lot of sense. I get emails all the time, or comments for CataractCoach. It's very popular, and we're getting it on all platforms combined, 1 million views a month.
Phenomenal.
So it's crazy numbers. But a lot of the comments are like, in my country, and often it's in Asia or South America, often it's in Europe and other parts, they say there's not a lot of surgical training. And so they're even going to other countries to learn how to do more hands-on. What advice do you have to that person? Let's say you're in Europe, and it's in a country in Europe, for whatever reason, the programs that are set up don't give you enough hands-on surgical training. Well, now what?
So I'm going to tell you whatever the reason is, and I'll be very blunt. People don't want to train the competition.
Oh, boy.
A lot of international fellowships were based on the fact that you came, got your experience, and went back to your country to share the knowledge, which was the deal I signed up for. And I had a phenomenal year in New Zealand, learning as much as I possibly could. I think industry have cottoned on to this, which is why you have ISASO, the European School of Advanced Studies in Ophthalmology. Alcon have their experience labs. Other companies also run dry lab facilities. Help Me See, you're trying to put a simulator in possibly Strasbourg. Bridging the gap. The sad reality in Europe is sometimes you have to catch the eye of the professor, which is dangerous and potentially abusive. You work hard in clinic and you hope that you might get the opportunity in theater. So come to the UK, because we have to train you. And there's a limit of doctors. If only Brexit hadn't happened. It's really hard. I mean, if you're in, particularly some of the Eastern Europeans, I've taught on many basic cataract courses, and they just don't have the exposure, or if the system is more private, then people aren't going to give you that opportunity. So surgical training is a real problem, and we have cataracts coming out of our ears. So who's going to actually do them? I think increasingly fellowships or observerships, which can maybe skill-based ones like for small incision surgeries or mission camps. People are making use of that. It's not brilliant. I didn't want to do any overseas work as a medical student in my elective until I was competent. But now with the skill base, I think I should be looking at doing some sort of a mission trip somewhere. Ophthalmology lends itself for short-term service. We've got Orbis. There's many opportunities out there to get involved. And a number of the universities have links within the UK to Africa, I'm sure in the US to South America, elsewhere. But getting involved, and again, having these discussions at a national and international level gives you a voice and gives you clout to then go to the decision makers. So after I do my courses, we try to give everyone some of these model eyes and say, bring that to your boss and say, can you talk me through a procedure? Or show them what you've done in this event or in this symposium. So you're giving them the confidence that you know what you're doing. So you're much more likely, you're going to be careful how I say this, you're much more likely if you catch your child doing good. So if your child comes to you and says, oh, can we do this? Look what I've done. You're like, oh, that's brilliant. Whereas if your child's like, entertain me, you're like, no, go and tidy your room. So if a trainee comes in and says, I was watching CataractCoach.com, can we talk about this video? I was reading this chapter in Kansky, can we talk about this condition? Oh, you've done some homework of your own volition. Of course we can chat. But when it's just teach me, it's like, no. You need to learn to be, we're supposed to live in a world of adult learning. So if you have access, you need access to the opportunity. But when you've got access to the opportunity, we need to make sure we make use of it. And I think I always respond better when someone comes to me and says, this is what I've done. It's like being on call. If I phone you and say, you must do this, you're like, oh, do I really? But if I say, Uday, can you help me? Of course, what do you need? So it's just basic communication skills. So all the training needs to do is go to their boss and say, I was reading about concession X. Can you explain it to me? Or I did this little presentation. Can you help me? Can you show me? Can you help me? Not turn up and go, I paid for this opportunity, so I expect you to do everything. And I think that's where the historical breakdown has come.
Well, I think that's great advice. The way you put it like that, coming with that type of attitude is more amenable or conducive to getting the help from these more senior doctors and you developing those surgical skills. That's fantastic.
I think so. And I've even found that at conferences, to go full circle, if I have reached out to someone beforehand and I go, people are busy, but if I reach out to someone before and say, can we meet, can we discuss, here's something I wanted to run past you, nearly everybody says, yes, that's fine. If I hope that I'm just going to bump into someone, invariably they're hitchhiking to a different part of the building, love to chat, can't stay. Millions of people are getting pictures with you, so I can't get anywhere near you. You know, it's just not conducive to that sort of cup of coffee we need.
No, such great advice. Well, I hope a lot of young ophthalmologists really enjoy this podcast and listen to it. There were so many great pearls. I look forward to seeing you soon, probably at the ESCRS. And then again, I will share a Thanksgiving with you in London and help inaugurate you as the new president of the UK.
Well, please don't either impeach or assassinate me. I hope it'll all work out very well.
Not to worry, but I come in peace. I come to just connect with colleagues, to honor the 75th anniversary, which is very important, and to actually just enjoy. Simple.
That's what makes life worth living. Uday, thank you so much for the privilege to chat. It's always entertaining.
Oh, thank you so much. And I want to remind our listeners and viewers, remember, got a new podcast every single Sunday, Apple, Amazon, Spotify, Google, wherever you get your podcast. And of course, every single day, we have a new CataractCoach.com video. Until next time, we'll check you later.